This video describes and demonstrates the steps in performing an emergency neonatal abdominal paracentesis. The most common setting for this procedure will be in the delivery room just after the birth of an infant with prenatally diagnosed or postnatally apparent abdominal ascites or hydrops fetalis with resultant cardiorespiratory compromise. If possible, equipment should be prepared in advance. If there is not adequate time to prepare in advance, consider delegating the task of collecting equipment to an available staff member. For this procedure, you will need ChloraPrep or another appropriate prep material like alcohol swabs. You should have several 18 or 20 gauge angiocatheters. You will need at least one 5 milliliter syringe and several larger 20 milliliter syringes. Having a 3-way stopcock available can make rapid removal of intraperitoneal fluid easier. Also consider having a sterile container or culture bottles available for diagnostic studies on the fluid. You should have supplies to sterilely dress the needle insertion site after the procedure, including sterile gauze and an appropriately sized tegaderm. Finally, you will need appropriately sized sterile gloves, hat and mask, and a sterile gown. If possible in the emergency delivery room setting, have the patient on heart rate and oxygen monitoring while the procedure is being performed. Perform a pre-procedure timeout immediately before the procedure. Confirm the patient's identification, the procedure and indication, and the procedure site.
This is baby boy Smith. We will be performing an abdominal paracentesis in the setting of hydrops fetalis. The location will be the left lower abdominal quadrant.
Position the patient in a supine position. Rapidly inspect the abdominal wall and note any congenital abnormalities or abdominal wall defects that may impact the success of the procedure. Rapidly palpate the abdomen. Note the location of the anterior iliac spines bilaterally. Consider marking these landmarks for orientation during the procedure. Select which side of the abdomen you will perform the procedure on. Consider the left if there is no contraindication. To avoid the liver, which is large in all neonates and can be enlarged in many underlying causes of hydrops fetalis and abdominal ascites. Identify the site halfway between the umbilicus and the anterior superior iliac spine in the lower abdominal quadrant on the sides you have selected. Mark the site with a pen or indentation. If you are not already wearing them, apply a cap, mask, and gown. Wash or sterilize your hands and apply sterile gloves. Double check your supplies. Attach an 18 to 20 gauge angiocatheter to a 5 ml syringe. Have additional 20 ml syringes attached to a 3-way stopcock available. Prep over the marked skin site and surrounding skin with ChloraPrep or another appropriate product as available. You should use a circular motion starting at the planned insertion site and moving from central to peripheral. Now you are ready for needle insertion. Consider inserting the needle perpendicular to the skin at the marked site, or use the Z-tracking technique. Z-tracking is accomplished by gently pulling up on the superficial skin, inserting the needle in a slightly caudal orientation, and shifting the needle to a slightly cephalad orientation as you advance the needle. In this video demonstration, we will be using the perpendicular skin technique. As you slowly insert the angiocatheter with needle, provide continuous aspiration. Stop insertion of the needle when fluid returns in the attached 5 ml syringe. Once fluid returns, slide the catheter over the needle and then withdraw the needle while leaving the catheter in place. Appropriately dispose of the needle. Attach a 20 ml syringe with or without a 3-way stopcock to the angiocatheter. If a 3-way stopcock is used, make sure that the stopcock is off to the unused port to allow fluid to be drawn back from the peritoneum and into the syringe. Slowly aspirate acidic fluid in 15 to 20 ml aliquots. Once the syringe is full, turn the stopcock to off to the angiocatheter to prevent leakage of fluid or contamination while you are attaching a new syringe. You should continue fluid removal as necessary for resolution of cardiorespiratory compromise or until no additional fluid can be drawn back. Once you have withdrawn as much fluid as you think is appropriate, pull out the catheter, gently apply pressure to the site, and then apply a sterile bandage. Consider transferring acidic fluid to a sterile container or capping the sterile syringe into which fluid was aspirated. Acidic fluid may be sent for diagnostic studies and culture to help determine the cause of abdominal ascites or hydrops fetalis. Finally, confirm that all needles or other sharps have been appropriately disposed of in a sharps container. After the procedure and stabilization of the infant, reassess your patient for procedural complications including hematoma, signs of intraperitoneal hemorrhage, continued leak from the insertion site, or signs of bowel or bladder perforation. After the infant is stabilized, you should also take time to document the procedure and timeout in the patient's medical record.